Hello, I'm Dr. William Miller from the University of New Mexico, and I want to offer you just a brief introduction to the method of motivational interviewing. Doing so is in a way like giving you a brief lecture on playing the piano. I can give you a sense of what it's like and some of the history of it, but it won't make you a competent pianist at the end. So this is just to give you a sense of where the method of motivational interviewing came from and how it can be used. Motivational interviewing really began on a sabbatical leave that I had in Norway. And I was working with a group of Norwegian psychologists there. And we were trying to solve some of the puzzles of how to work with people who needed to change, but didn't seem quite ready to change. This was at a hospital for people with alcohol problems. And out of our discussions came this method that we called motivational interviewing. Here are some of the basic concepts. First, it is the client rather than the counselor who should be making the arguments for change. Second, you're trying to evoke, to understand, to hear the client's own motivations and concerns and have them talk about that and hear themselves say it. It involves listening well with empathy to understand what the person means. And if you meet something that feels like resistance, don't push against it. That just strengthens the resistance. Instead, you sort of roll with it or go with it and keep listening well. Certainly, you want to nurture hope and optimism that it is possible for change to happen. And the name that we gave it, motivational interviewing, reflects both that it's about motivation, it's about the client's own motivation. And in English, at least, the word interviewing is power neutral. It doesn't tell you who's in the more powerful position. You might be a lowly college student interviewing a famous visiting professor. You might be an employer interviewing potential employees. You can't really tell just from the word interviewing. And so the neutrality of that term, the fact that it's a conversation, is what we were looking for. We might have called it motivational conversation, except that in a conversation, the two partners don't have different roles. Whereas in an interview, someone does have a particular role, and that's what's happening in motivational interviewing. Initially, we thought of this as a preparation for treatment, something that you might do at the beginning to help people get ready for treatment. But as we began doing research with motivational interviewing over the decades, 8 surprises emerged, and I want to first tell you about those. First, although it started out as a way of helping people with alcohol problems, and then soon after that, other drug problems, it quickly spread into healthcare, and then into corrections, and then social work, and dentistry, and many different fields, because it turns out that ambivalence about change, problems with readiness to change, occur in all sorts of professions and in many different areas. There are now more than 1,500 controlled clinical trials involving motivational interviewing, and 160 meta-analyses and systematic research reviews pulling together research on motivational interviewing in particular areas. So the discovery was this method that we had initially developed for helping people with alcohol problems to get ready for change is much more broadly applicable than we had initially imagined. Second, MI can be effective in relatively brief format. The usual length of motivational interviewing in clinical trials is 1 or 2 sessions, at most 3 or 4. And it has been used effectively within the context of healthcare visits where there's not a lot of time. So maybe just 10, 15 minutes of conversation. And nonetheless, there are positive results. So the surprise was this wasn't just a preparation for treatment, that having a conversation like this with people in itself often helped them to turn a corner and begin to change something that had been a pretty long-lasting behavior pattern. Third, you can learn MI. Skills in MI increase with training, and particularly with some individual feedback and coaching, just like learning a sport or a musical instrument. And we found that the ability to learn the clinical style of motivational interviewing is not related to the number of years of professional education or years of experience. We also discovered that just taking a workshop in motivational interviewing or just reading about it doesn't really improve your skill that much. Although people who've taken a workshop sometimes believe, now I've got it, now I can do it. But in fact, when you listen to practice, it isn't there. The effectiveness of motivational interviewing is highly variable. Some studies find that it's effective, some studies find that it's not. About 60% of studies have had a positive finding. Within studies, large differences among therapists in the outcomes of their clients, even though they're all supposedly doing the same thing. And in multi-site trials, motivational interviewing has worked at some sites and not others. That's interesting. What's that about? Well, it turns out that we can reliably measure the skillfulness with which motivational interviewing is being offered. And the quality of motivational interviewing that's being offered predicts outcome. So the more faithful the clinician or the study or the site is to the method of motivational interviewing, the better the client's outcomes tend to be. We also discovered that you can predict the outcome of treatment from what clients are saying during the session. There are particular things that you hear clients say that predict they'll have better or worse outcomes. And therapists have a large impact on what clients say, on what we call change talk and sustain talk, during treatment sessions, and thereby on the outcome of treatment. 6, when motivational interviewing has been compared with longer and more intensive kinds of treatment, there usually has been little or no difference in outcomes. So even though motivational interviewing has been shorter, briefer, its impact has been about the same on average as longer kinds of treatment with the same goal. This means that if you deliver motivational interviewing as your first visit with a client or patient, you've given them something that's likely to help them, even if they don't come back. A 7th finding is that motivational interviewing, when it's added to other treatments, seems to improve their effectiveness. In fact, both things work better. The most common combination has been motivational interviewing with cognitive and behavior therapies, but it really combines well with a whole variety of other kinds of treatment. And that's the way it's being used. Increasingly now, studies of motivational interviewing are not looking at motivational interviewing by itself. There were quite a few studies like that, but rather being used in combination with other forms of treatment. Finally, we found that motivational interviewing crosses cultures well. I know of at least 56 languages around the world where motivational interviewing is being taught and practiced. And clinical trials are appearing from Africa, Arabic nations, Asia, North and South America, Europe, and Oceania, all around the world. We also found, to our surprise, that in the United States, the effect of motivational interviewing was larger, significantly larger, when the people being treated came from a cultural minority group. Mostly in America, this is African American and Hispanic American people. So that, and the therapists were mostly white, non-Hispanic. So that's an interesting one too, that when delivering this treatment to someone from a disadvantaged or marginalized group, it seems to work better, not just as well, but even better. And I think that motivational interviewing has something to do with human nature, that it crosses such different cultures and lands and grows in places with so very different backgrounds, that I think this is something common about human nature that we're talking about here. Now, treating addictions is where we have the most evidence. Treating alcohol problems is where it began in 1983, and the largest scientific base for efficacy is in treating addictive behaviors, particularly smoking, marijuana, and alcohol. I met Steve Rolnick on a second sabbatical leave in Australia. And he had actually read my 1983 paper and encouraged me to write more. And so I had him tell me what he was doing with this, and he was actually teaching motivational interviewing in the United Kingdom, where it had become a popular component of treatment for addictions. And so I said, look, why don't we write a book together? And that's what we did. We've now written 3 editions of the motivational interviewing text together. The first one in 1991, most recently the 3rd edition in 2013. And we're working on a 4th edition. So what is this? Motivational interviewing is a collaborative conversation style, so there's sort of a partnership feeling to it, for strengthening a person's own motivation for and commitment to change. From the practitioner's perspective, this is a person-centered way of counseling, of having a conversation about change that addresses the very common problem of ambivalence about change, of not really being sure whether the person wants to make this change or not. That's where people can get stuck for a long time. Part of them knows that they need to make a change. If you get a diagnosis with a chronic illness like diabetes, you know that there are things that you should do differently. And part of you is also very comfortable doing things the way you've been doing them. And you can stay stuck there for a long time. We originally designed motivational interviewing for those folks, for people who were less ready to change. If people came in all ready to go, ready to say, I want to change, just tell me what to do. From my behavior therapy training, I had some good ideas for them. But I found that often that wasn't the case. And ambivalence is kind of like having a committee inside of you, where there are voices both favoring change and opposing change. And both those kinds of voices are at the table. Now, we know that a patient's readiness for change is important. And in the addiction field, we used to just say, well, go away and come back when you're motivated, and then we can help you. But that's not good enough. There's something that you can do to help people's motivation for change increase. And ambivalence is perfectly normal. In fact, it is what describes, if you're familiar with this stages of change model, it is what describes the contemplation stage of change. So in pre-contemplation, the person isn't really thinking about change at all. But in the contemplation stage, they can see some reasons for change, and they can see some reasons not to change. And that balance is just tipping back and forth. When the balance begins to tip, you get to the preparation stage, beginning to think about, well, what could I do? Is there a way that this is possible for me? And if you find a way that's successful, then you get into the action stage of actually making that change. Now, as a behavior therapist, I was taught how to help people who were in the action stage, but I wasn't taught really much of anything about how to help people who weren't yet ready for action. And that turns out to be, at least in addiction treatment, maybe 80% of people coming through the door. So it was important to find a way to help people change. Now, something that we realized is that people go into helping professions because they want to help. And for some reason, the thing that we tend to do when we want to help is to tell people what's wrong and tell them what they need to do about it. But human beings in general don't respond too well to being told what's wrong with them and what they should do. Yet it's what we as helpers are kind of most likely to do, to essentially make the arguments for change. So what happens when a helper with the writing reflex meets a person who's ambivalent? The helper is taking the good arguments. The helper is voicing the reasons for change and why it's important and how to do it, so the why and the how of change. And the natural response to that from the patient's perspective is, well, yes, but. So the clinician may say, I think you have a serious alcohol problem. And the patient says, I don't think it's that bad. And the clinician may say, no, you need to stop drinking. And the natural response is, no, I don't. And so you're kind of acting out the person's ambivalence, with the clinician taking the good lines and causing the client to argue against change, which is a natural response. But that's not a good thing, because most of us tend to believe ourselves. So when we hear ourselves talk, we tend to say, that's right. So if you counsel in a way that causes your clients or patients to argue against change, they're actually unlikely to change. Motivational interviewing is sort of the opposite of that. It's arranging the conversation in a way that it's the client who makes the arguments for change. These are normal responses to the writing reflex. These are normal human responses to being told what's wrong with you and what you should do. People tend to feel resentful about that. They may get angry, or they may feel ashamed or embarrassed. It's certainly not comfortable. And they don't feel understood. They don't feel heard. And interestingly, they don't feel able to change. A second kind of response to the writing reflex is to resist, to argue back, to discount and minimize and be defensive and maybe dismiss you as a credible person, or to justify what they're doing right now, to justify the status quo. And a third reaction to a clinician who's using the writing reflex is to retreat, is to get out of there, to not come back, to not listen, to be passive, to not like the clinician, to want to avoid and get out of there as quickly as possible. Those are normal reactions to telling people what's wrong with them and what they should do about it. In other words, causing people to feel bad doesn't help them change. Some of us have a strange idea, and it's kind of common in the United States, that if you can just make people feel bad enough about themselves, then they'll change. There never was any good science behind it. It's not a particularly effective approach. So what's motivational interviewing? We began teaching techniques, and we quickly discovered that if we only taught the techniques, it didn't sound right. There was something missing. And we realized what was missing was the mindset, the heart set, the attitude with which you use these methods. And there are 4 components to it. One of them is collaboration. This is a partnership. We're not walking out in front of the person and trying to get them to follow us. We're not walking behind the person and pushing them. We're walking beside the person and taking a journey together. It's a collaboration in that sense. Both the clinician and the client have expertise. No one knows more about your clients than they do. And if what you want is for them to make a change in how they live their lives and in what they do, you need their expertise because they know so much about themselves as well as your own expertise. Compassion, yes. A commitment to the other person's well-being, a commitment to alleviating suffering. That the reason we're sitting here is not for my benefit. The reason we're sitting here is for the well-being and health and happiness of the other person. Evocation, To evoke is to call forth, and that means calling forth from the person that which they already have. Sometimes in our minds as helpers, we have this message, I have what you need and I'm going to give it to you. The message in evocation is you have what you need and together we're going to find it. So it's believing that your clients have good ideas, your clients have wisdom, your clients have experience, and you can draw on that. And then finally, profound acceptance of people as they are. So when someone comes through the door, they don't need to prove to you that they deserve respect. As a human being, they do. There's something about feeling unacceptable that makes it very hard to change, which I think is one reason that shaming and blaming is not very effective. When you feel unacceptable, you're kind of stuck. It's very difficult to change. Whereas, ironically, when you experience acceptance of yourself as you are, it becomes possible to change. That acceptance may come from a therapist, it may come from a friend, it may come from God, wherever it comes from, a teacher. Wherever you experience that acceptance, it's freeing and makes it possible to change. We now teach motivational interviewing as having 4 processes. The first of them is engaging, forming a trusting working relationship. That mostly is done by good listening, by really trying to understand the person's perspective and how they're experiencing their situation at present. The underlying question in engaging is, can we walk together? The next process is focusing. What are our goals? Why are we working together? What is it that we hope to accomplish? And so the underlying question here is, where are we going? Then the third process, the one most unique to motivational interviewing, is evoking, which is calling forth the person's own reasons, their own motivation, their own desire, their own ideas about how to change. And then finally, when there seems to be enough motivation to proceed, to begin to develop a plan for how to do it. So again, the underlying messages, can we walk together? Where are we going? Why do you want to go there? How will we get there? Now, the engaging skills we owe very much to a psychologist named Carl Rogers, who did his work in the 1940s, 50s, and 60s. And we use skills directly out of Rogers' person-centered method, asking open questions to which you don't know the answer and that invite the person to talk to you. Affirming, looking for strengths, looking for everything the person's doing that's a good step in the right direction. Listening well, reflective listening, very important skill in motivational interviewing, and being able to offer summaries as well. But we do that in particular ways. So you need to be a good empathic listener. Accurate empathy by itself is associated with better outcomes across many professions. If you listen well to your clients and patients, they're more likely to change. And this is a measurable skill. You can listen to a practice tape and accurately rate the extent to which accurate empathy is present with that clinician in that setting. High therapist empathy, as I said, is associated with better client outcomes and more change. And sadly, clinicians who are low in this skill of accurate empathy tend to be worse than no clinician at all. So you're better off not having a therapist than having one who's low in empathic skill. So empathic therapists have clients who are more likely to come back, who are less resistant, and there's kind of just less fight against change, and are more likely indeed to change. That's a fundamental skill in motivational interviewing, and one of the first things we focus on in training. But we also focus on what the client is saying, and in particular, what we call change talk, which is any speech that suggests the client is taking a little step or moving in the direction of change. Now, to know if it's change talk, you need to know what your goal is. So if the goal is to help the person change their drinking, if they're saying, I want to stop smoking, that's change talk about smoking, but not about drinking. So it matters what your goal is. We learned a lot about different forms of change talk. And these four, I think, are present in almost all languages. And we call these preparatory change talk because these are sort of getting ready for change. One of them is desire. In English, the words are I want, I wish, I would like. But every language on the face of the earth has a way of saying I want. That's one kind of change talk. What does the person want? Then there's ability language. I could, I can, I'm able to do that. Person may say, I could stop drinking, but I don't want to. So you have ability language on one side and desire on the other. Reasons to change have a kind of if-then quality. If I do make this change, I think these good things would happen. And if I don't make this change, I think these bad things may happen. And then finally, there may just be a kind of urgency. I have to change. I've got to do something about my drinking. I really need to be a better husband to my wife. Whatever it is, there's an urgency to the language. It doesn't necessarily give a reason yet, but it's there in the client's talk. Then these three kinds we call mobilizing change talk because they have a little more momentum to them when you start hearing these. Commitment language is, I will, I intend to, I have decided to, I promise to. And activation language is almost there. Well, I'm willing to, I'm ready to, I'm prepared to. And the other thing we noticed was that when people come back to a session, they have often done things in the meantime that do move them a step closer to making the change. So let me give you some examples. This is change talk about the use of alcohol. And first, preparatory change talk. I wish I could quit drinking. That's desire language. I think I could do it. That's ability language. My family would be happy if I quit. That's a reason. I have to do something about my drinking. That's a need. It's important, is the message there. I'm going to quit. That's commitment language. It's how we make promises to each other. I'm willing to quit. Activation language. I poured out all of my alcohol today. I got rid of it, got it out of the house. That's taking steps. So these are things you'll hear normally from people who are ambivalent. You'll hear change talk. In fact, preparatory change talk, when you're trying to evoke that, it feels a little bit like walking uphill. It's a little bit harder work. And when you begin to hear mobilizing change talk, it's a little easier. It feels more like kind of going downhill. You can still make mistakes, but there's just a different feel to it. And if you know those trans-theoretical stages of change I talked about, the kind of talk maps pretty well onto where the person is in their readiness for change. Now there's an opposite side of the coin. The opposite side of change talk is sustained talk, which is in essence arguing not to change, arguing for things to stay the same. So here's sustained talk, again about alcohol. I really enjoy drinking. That's desire to keep drinking. I don't think I could quit. An ability statement, actually an inability statement. Drinking is the only way I have to relax, a reason to keep drinking. I don't need to quit. It's not important. That's a need statement. I intend to keep drinking and nobody can stop me. That's commitment language. Yeah? I'm not ready to quit. Activation. I bought 4 bottles today. That's taking steps to keep drinking. So normally when people are ambivalent, you hear this balance of change talk and sustained talk. You hear them both. They come in the same sentence. And that's not pathological. That's not abnormal. That's usual. That's just what ambivalence is all about. But a key point is that you can influence the balance of change talk and sustained talk that you hear during a session, and that matters. If you had on the left side just an equal amount of change talk and sustained talk, that's a pretty good definition of ambivalence, and you wouldn't expect change to happen right then. When you begin to hear about twice as much change talk as sustained talk, that's the balance tipping toward the preparation stage. And we've learned through our research that clients arguing against change actually has more impact than them arguing for change. So what you don't want to do is counsel people in a way that causes them to argue against changing, because it's very persuasive. When we hear ourselves arguing against change, we tend to believe ourselves. It's at least as important to decrease sustained talk as to increase change talk. So is that possible? Here's a study done by Lisa Glynn and Terry Moyers, where they had the counselor change their style every 12 minutes, if you can imagine that. Now, the client was not aware of this. There was a little signal light on the wall that told the therapist what to do. And the 2 things that they could do were either something like motivational interviewing, where you're trying to evoke the person's change talk, or a behavioral procedure called functional analysis, which is about understanding the antecedents and consequences of drinking. So they went back and forth between 12-minute periods of these 2 styles. Now, the clients experienced it as one smooth interview, so they didn't really notice anything different. But look what was different. In this first bar over here, the first session of motivational interviewing, they're getting 1.6 times more change talk than sustained talk. Then in the second bar, where they've gone to functional analysis, the direction reverses. And now there's more sustained talk than change talk. Then the therapist switches back to motivational interviewing, and now it's 2 to 1. Twice as much change talk as sustained talk, which I told you is about the threshold for change to happen. Then switch back to functional analysis, and again, you're back almost to ambivalence. So you can influence the amount of change talk and sustained talk that you hear, and that predicts client outcome. Once you recognize change talk, once you've tuned your ear to hear it, and to know that when you hear one of those statements, you've just heard something important, the next set of skills in motivational interviewing is learning how to invite or elicit or evoke change talk. And we have a variety of ways of doing that, the simplest of which is to ask a question, the answer to which is change talk. Why would you want to stop drinking? What do you think would be 3 good reasons why you might do that? What do you suppose will happen if you continue drinking as you have been, or even increase your drinking? Where do you think that road leads? So you're asking open questions, the answer to which is change talk. We have a variety of other methods. I won't go into detail with them here, but in essence, they're ways of inviting people to tell you their own motivations for change. And then once you've done that, you need to learn how to respond to change talk to strengthen it. And so when you hear a change talk statement, don't just sit there. You can ask for elaboration. You can ask the person to tell you more about that. Well, I think I'd feel better in the morning if I weren't drinking. Really? In what ways do you think you would feel better? Or Tell me about the last time you woke up and felt really terrible. What was that like? So you're looking for more detail or examples. Or you can comment positively on what the person said. I think I probably could quit smoking if I really put my mind to it. Oh, so you're that kind of person that if you really decide, you can get something done. You can reflect what the person says. My family would be happy if I quit drinking. You think your family would be better off. They'd actually be pleased if you stopped drinking. And summarizing, it's listening to all the things the person has told you. So we think of these change talk statements as being like flowers, and gathering together all of these statements of change talk that the person has said and offering it back to the person like a bouquet. So here are all the things you've told me that are your motivations for change. What about when you hear sustained talk? Because I've told you it's at least as important to soften or decrease sustained talk or discord, this tension in the working relationship. And some of the most effective ways we know of doing that, again, involve reflective listening. You don't understand how hard this is for me. This really is difficult for you. Simple reflection. Or an amplified reflection. It sounds like this is one of the most difficult things that you ever thought about doing. Or a double-sided reflection. So on the one hand, this looks like a really hard thing to do. And on the other, you can see some reasons for doing it. Sometimes just apology. You aren't listening to me. And you say, I'm sorry. I need to listen better. So tell me what it is that I'm missing. Or just shifting the focus. When people say to me, you telling me I'm an alcoholic? I usually said, I don't really care about putting labels on people. What matters to me is you and what's happening in your life and what, if anything, you want to do about it. So I've shifted from arguing about a diagnostic label to compassion and concern for the person. And a really good one is just telling the truth, which is emphasizing the person's autonomy and their ability to control. I don't want to quit drinking. And that is your choice. Nobody else can make that decision for you. It really is up to you. These things just kind of take the wind out of the resistance sails. And that's important. So how can you use motivational interviewing? Well, it can be used as a standalone opportunistic intervention. Just in the middle of a healthcare visit, you can do 5 or 10 minutes of motivational interviewing. And there's a clear effect to motivational interviewing just by itself used in that way. And as I said, often comparable to more intensive treatment. You can use it the way I originally imagined as a preparation for treatment. And we found that when you do this at the beginning of treatment, people are more motivated for treatment and they're more adherent to treatment and they have better outcomes. You get larger, more enduring effects. And you actually can become a clinical style with which you do treatment, a kind of way of doing diabetes education or a way of doing cognitive behavior therapy, a way of doing primary care. It's a way of doing what else you do. What about teaching and learning motivational interviewing? I've already told you that just reading and watching videos about motivational interviewing doesn't produce an increase in skill. And coming to a 2-day workshop with me produces small and temporary changes in competence, and not enough to make any difference to your patients. But I did find that people who came into a 2-day workshop with me now believed that they were doing MI well. Yet when we listened to practice tapes, it wasn't there. So I was, in a way, I was doing something pernicious. I was instilling a false confidence that they had learned it. And what we find does make a difference beyond the initial workshop training is to get some personal feedback and some coaching, which is the way you learn a sport. If you hire a tennis coach to help you, you would never say, "Don't watch me." I'd be too embarrassed. You want the coach to watch you and to make suggestions, even little ones. Like on the backhand, now turn your wrist just a little bit. Now try the backhand again. There you go. How's that feel? That kind of gentle, specific coaching is helpful in learning motivational interviewing. And it doesn't necessarily take a lot of it. In one study, we found that 5 half-hour telephone coaching sessions were enough to get people up to a level of competence that I would be happy to hire as a clinician in a clinical trial of motivational interviewing. Also importantly, when people had a workshop and got feedback and coaching, their patients behaved differently. We're now hearing more change talk, and that's the thing that tells us that change is more likely to happen. So we've been at this for 4 decades. What have we got? We have a clinical method that's evidence-based, literally 1,500 clinical trials around the world. That's relatively brief. This is not a long-term psychotherapy. This is something that can be done in a reasonably brief period of time. It's specifiable. We can tell you how to do it, give you clear guidelines on what good practice looks like. And it's verifiable. We can listen to practice samples, 20 minutes of practice on tape, and with good reliability, rate the quality of motivational interviewing that's being delivered, which in turn predicts better client outcomes. We understand some of how it works. The empathic reflective listening is really important. And it's clear that change talk and sustained talk are important as well. It seems to be generalizable across a broad array of practice. It's adaptable across cultures. I mean, it's amazingly adaptable in very different cultures from the one in which it began. It's complementary to other treatment methods, so you don't have to be converted to this method and give up what you were doing before, but rather it can be put together with motivational interviewing. And it can be learned by a very broad range of providers without regard to years of education. And even with all of that, and I'm happy with that, I still have the sense that we're just getting started, that we're just beginning to understand how it is that we can be helpful to people. We know an encouraging amount about it, and we have an encouraging ability to teach others to be more helpful, and yet there's so much more to learn. If you're interested in learning more, here is the website of the International Motivational Interviewing Network of Trainers. And I hope this introduction has been useful to you.